record. Good afternoon and welcome to our HIV Prevention and Education Virtual Summit presentation entitled "End the HIV Epidemic Update, Creating a Disruptive Community." We are joined today with panelists from the Philadelphia Department of Public Health's AIDS Activities Coordinating Office. Before we begin, I'd like to go over a few reminders. Viewers, please make sure your mics are muted. The chat box is disabled, but you can ask questions using the Q&A box located at the bottom of your screen. Reminder, this presentation is being recorded. Q&A questions will take place at the end of the presentation. At this time, I will turn it over to our wonderful panelists and we can begin the presentation. Thank you.
Good afternoon, everyone. Thank you very much for participating in this afternoon's webinar. My name is Dr. Kathleen Brady. I am the Acting Director of the AIDS Activities Coordinating Office of the Philadelphia Department of Public Health. Let me go to the next slide. And first of all, I wanted to introduce you to our EHE team that will be presenting this afternoon. We have Javante Williams, who's the Senior Coordinator of HIV Prevention Services with us. Tanner Nassau, who's the Ending the HIV Epidemic Evaluator, Anna Thomas Ferrioli, who's the Ending the HIV Epidemic Advisor, Brian Hernandez, who's the Telehealth Program Coordinator, and Amina McCann-Woods, who is a Health Program and Analysis Supervisor. And before we move to the next slide, we also have a special guest, Evan Thornburg, who is our Health Equity Advisor, who is going to be available for questions and answers this afternoon regarding our health equity initiatives. And I also want to mention that ACO is comprised of about 100 staff from various disciplines, and this presentation is only possible because of their contributions. So thank you to them. So what we're going to present today is an update on the Ending the HIV Epidemic Federal Initiative and the Philadelphia EHE Community Plan. We're going to talk about building a disruptive community to end the HIV epidemic in Philadelphia. We're going to talk a little bit about future forward, which meaning our progress towards our goals. We're going to have prevention program updates, as well as some harm reduction activities update, and lastly, an EHE regional collaborative update. Why don't we go to the next slide? And with that, I'm going to turn it over to Anna.
Hey everyone, my name is Anna Thomas Ferrioli. I'm the EHE advisor in Philadelphia Department of Public Health ACO team. Next slide, please. I'll be talking with you about the federal initiative and how we translate that here locally in Philadelphia. So the federal Ending the HIV Epidemic initiative has a goal of reducing new HIV infections by 75% in 5 years, and then by 90% in 10 years. This initiative started with its first implementation year in 2020. So this is a 75% reduction by 2025 and a 90% reduction by 2030. There are 5 pillars to the federal plan. It's to diagnose all people with HIV as soon as possible, to rapidly treat the infection and achieve sustained viral suppression, to prevent people at risk for HIV from acquiring HIV, using a variety of interventions, to respond rapidly to HIV outbreaks, and to shore up the HIV workforce. Next slide, please. So in Philadelphia, we are one of the leading cities with more than 50% of new HIV diagnosed between 2016 and 2017. We are considered we were one of the first cities. We were in the first group of cities chosen to implement EHE activities around the country. On December 1st of 2020, the Philadelphia Department of Public Health ACO released the Ending the HIV Epidemic Community Plan. This plan was created by Philadelphia community members. Together, we identified strategies to reduce new HIV infections by 75% here, which would be 118 new cases a year by 2025, and to reduce by 90% by 2030 to about 47 new cases a year. In 2019, there were 440 new infections, and in 2020 it was much lower, but those numbers really were impacted by reduced testing during the height of the COVID pandemic. Next slide, please. This is our modified HIV care continuum. It's modified because the base number of 14,714 is the number of people that we believe to be still residing in Philadelphia and living with HIV. It's an estimate because we don't know everyone who has HIV. Not everyone gets tested and not everyone knows their status. So it's estimated that about 78% of people living with HIV are in care. About 46% of them were retained in care in 2020. And then about 67% were virally suppressed, which means that they had a viral load below 200 copies per milliliter. Next slide, please. The Philadelphia Community EHE plan is a really great blueprint, and it is my job here to carry forth the initiatives identified in this plan and to really work closely with all of my colleagues across ACO to make sure we're moving forward with our efforts to end the HIV epidemic. So we have 5 pillars here. It's a little different than the federal. I'm going to diagnose all Philadelphians with HIV as early as possible, treat people with HIV quickly and effectively, prevent new transmissions by promoting PrEP, which is pre-exposure prophylaxis, PEP, which is post-exposure prophylaxis, and syringe service programs, also known as syringe exchanges or needle exchanges. Respond quickly to HIV outbreaks. And Philadelphia has a pillar 0, which I believe is very important, which is based in using health equity and radical customer service as a core practice, because if we need to right the structural wrongs in order to end the epidemic in Philadelphia. Next slide, please. So the first pillar is to diagnose, and our goal is that by 2025, 95% of people living with HIV will know their status. Unfortunately, we estimate that about 1 in every 10 Philadelphians living with HIV don't know they have HIV. And when you don't know you have HIV, you can unknowingly pass it to other people. You also don't have the chance to get treatment to improve your health. So in the last 10 years, there have been a lot of efforts to get healthcare providers to offer HIV tests to everyone. This is known as routine opt-out testing, but still not all providers in Philadelphia offer opt-out testing, so we continue to work on these efforts. Next slide, please. Pillar 2, which is about treating people living with HIV, our goal is really about the result of treating people with HIV. Our goal is that by 2025, 95% of people living with HIV will be virally suppressed. Right now, all Philadelphia people living with HIV engaged in the care system, of all the people living with HIV engaged in the care system in the past 5 years, these are the individuals we believe are still here in Philadelphia. 78% received care during 2020. So we still have a ways to go. Retention in HIV care did decrease during the pandemic. This was due to less lab testing being done during the pandemic. Viral suppression decreased, but not as much as retention and care. Next slide, please. There's a lot that we can do to improve things, to improve treatment for people living with HIV. We can treat people rapidly and effectively to reach stable viral suppression. We can promptly link people newly diagnosed with HIV to care and treatment. One model for this is rapid start or same day start. This is where an individual starts taking HIV medication the day that they have their first reactive test. This is a good practice because sometimes you can lose people. Once they have that first reactive test, they might go home and become overwhelmed with other parts of their lives, and they're sort of hard to re-engage back into care. We want to find new and effective ways to re-engage people living with HIV. There are about 3,000 individuals locally who know they have HIV but are not currently in care, and support those already in care who are not virally suppressed to achieve viral suppression. Next slide, please. Prevention is very important to ending the HIV epidemic, of course. So by 2025, our goal is that half of the people with a PrEP indication will be prescribed PrEP. And all of the people who are seeking non-occupational post-exposure prophylaxis, which means that they believe they could have been exposed to HIV, anyone who believes they could have been exposed to HIV, that if they're trying to get PEP, they can get it. We have had gaps in our system that we are working to address. Not enough people at risk for HIV maybe think about themselves as being at risk and or are maybe ready or want to take PrEP. There's not enough data to really get to the number of people who are on PrEP. There's a need for expansion of syringe service programs because the nature of the current opioid crisis. The widespread use of fentanyl means more frequent injection, which means more need for more clean needles. And finally, low awareness of and access to post-exposure prophylaxis. Next slide, please. There's some things we're doing to work on this. We are working to increase access to low threshold pre and post-exposure prophylaxis, so PrEP and PEP. We want to make sure there's access to syringe service programs, provide harm reduction services, and connect to substance use disorder treatment, and provide HIV prevention activities for community at risk, including for pregnant people. Next slide, please.
Are you all aware the screen stop share? Okay. Yep.
Yeah. All right, our last main pillar is pillar 4, respond to HIV outbreaks. Our goal is to identify and investigate any active HIV transmission clusters and respond to any outbreaks we're seeing. And this we want to do so we can stop the chains of transmission and prevent forward spread of HIV to more people. So we have an outbreak response plan, and we need to carry it out when an outbreak or a cluster of cases gets identified, and we do so, and then make some systemic changes based on the data. Next slide, please. There is currently an outbreak among people who inject drugs. It was identified in 2019. And what we saw is that the number of new HIV diagnoses among people who inject drugs, including men who have sex with men who inject drugs, steadily rose from 2016, which was sort of the lowest point since the introduction of syringe service programs, and then to a peak in 2019. Cases were lower in 2020, again, due to less testing during the height of the COVID pandemic, but they have been increasing since that time. We at ACO are currently working to address this increase and will be rolling out a variety of activities. Next slide, please. Pillar 0, this is foundational, so important. It's about promoting health equity throughout systems and social structures. These have historically operated as barriers for many marginalized and communities of color. We do this by providing radical customer service at all levels, reducing HIV stigma through education, awareness, and anti-bias programs, providing safe and secure housing, and flipping the public health script to focus on systems and improving systems to make them more accessible, rather than focusing on the behavior of individuals. So rather than calling an individual hard to reach, you would call a system hard to navigate, and then adjust the system accordingly. Next slide, please. There's a lot of great progress. There's a lot going on, and you can track the data. We have a Philadelphia EHE dashboard. It has interactive tables. If you're really interested in a certain population or a certain year, a certain outcome, like viral suppression, you can go into this tool and click around and see different and produce different charts. I think it's a very cool tool. Colleagues who are much more savvy than me at these kinds of things developed it, and the link to it is on the slide. There's also a national dashboard called the EHE dashboard. It's a national level EHE dashboard that also has state level profiles. So you can go in, you can choose a state you're interested in, and that's the link for that is at the bottom of the page as well. Next slide. All right, thank you for your time.
Hello, everyone. I hope you can hear me and I'm not just speaking into the void. My name is Javante, and as Dr. Brady said previously in the introductions, I'm the Senior Coordinator for HIV Prevention Services, and I'll be talking in just a few minutes about what a disruptive community is, because you probably came to this presentation attracted to the title, and you're like, what in the world is a disruptive community? But I want to take you back. Some of you who come to this meeting annually may remember this slide. We presented this slide in 2020, then under our director Coleman, with Evelyn and some other colleagues from the health department. And I just want to remind you that we are dreaming big at ACO within the Philadelphia Department of Public Health. What would happen if we dreamed even bigger? If we reached for what was within our grasp, improving access to treatment and to pre-exposure prophylaxis, reimagining our communities and our work, focusing on what we have the power to improve, addressing our organizational differences, which are there, but championing what we have in common. What if we replicated what we know works, right? And we're doing all of this in the midst of a pandemic, a global pandemic. COVID has literally changed all of our lives and turned things upside down. This generation will mark its time by the start of COVID and what happened after COVID. We know that there's going to be effects on mental health, both short and long-term, emotional stress. And this is a crisis, but it's also a challenge and an opportunity to champion changes in our system. And we're seeing that. It's a unique challenge for service delivery, expediting innovation and forcing us to consider how we plan and provide services. And so when we think about disruption, I want to take you back to like the Walkman, right? I remember riding my bike as a little boy, having a Walkman. How many people have a Walkman that they actively use today? Very few of you, right? We think about things like the Rotary Club as the only networking environment, the only networking outlet. And now we have things like Facebook and Twitter, right? Or we think about the Who's Who publication that used to be printed annually, but now we have LinkedIn. Or encyclopedias. I remember door-to-door encyclopedia salespeople being a thing. And now we have Google, where the entire history of human civilization is at the tips of your fingers, right? So we think about this thing called disruptive innovation, which our federal partners have called for again and again and again, right? And we look at disruptive innovation, which was a term that started to become popularized in the mid-90s. How has public health employed disruption? We've seen mobile health applications. We've seen the increase of telemedicine and retail clinics, medical services where you may not have considered them before. But why do we need disruptive innovation in public health? And I'll tell you this, it's because it keeps pace with population changes. The population will shift, the focus will shift, If I told you to do outreach by putting bookmarks in books in the library or the bookstore in the gay and lesbian section, you'd look at me like I've lost my mind, because we know that that's not an effective way to outreach people right now. If we really want to increase our outreach, we would look to social media. But why do we need disruptive innovation in prevention and care? Because traditional ways of outreach don't work with patients who are younger, and as we see, people who are aging with HIV and at risk for HIV acquisition. So what does it mean to create a disruptive community? A disruptive community is a community that stands together shoulder to shoulder across the disciplines, across the governmental spectrum, and says, we're disrupting norms that don't work for all people. We're speaking out about harmful messages and stigmatizing provider health practices. We're disrupting stigma. We're becoming champions for HIV education in our own communities and supporting people living with HIV. We're disrupting barriers by engaging with providers through community advisory boards and feedback requests, as well as surveys, so that when providers need to know what things that they can do to improve services for people living with HIV and at risk for HIV acquisition, they will have data from the community and people with lived experience. And I ask you, when we think about creating a disruptive community, I often think about ACT UP and the early days of the epidemic, where there was severe disruption and demands for legislation, which is how we ended up with the Ryan Wright legislation. And I ask you to consider, do people still care about HIV? Even though we have it within our power to end the epidemic, do people still care about HIV? And this is where and why we need these disruptions. We need disruptions at barriers to prevention and care tools. We need disruptions because not all deaths are physical. And there is death of the spirit and the emotion lingering from the impacts of generation stigma. But we most importantly need to know how to actually cause disruption. And that's by listening to each other, respecting our differences, and fixing policy together. So how is ACO leading the charge to combine disruptive innovation with community? And we're doing that through ongoing community engagements, through our projects like the Medical Monitoring Projects, the National HIV Behavioral Health Survey, our Data to Care program, and our DEXIS program, which DEXIS stands for Demonstrating Expanded Interventional Surveillance, where we ask people who are newly diagnosed with HIV in our priority populations, what happened? What did the system do to fail you? Did you understand PrEP? Did you know about PrEP? Was it easy to get, right? What things can we do differently so that this doesn't happen again to anyone else? We're also focusing on a reimagined workforce with updates to our educational offerings and requirements so that we're training today's testing and outreach workers how to link people to care and prevention services that are effective for them. We're expanding our partnerships with other partners and co-creating new programming like the INPEP Center of Excellence, which is the first of its kind in Philadelphia, and creating a brand new Teleprep program, which you'll also hear about later in today's presentation. And we're bringing attention to policy areas through advocacy, like ACO's position statement for HIV decriminalization, so that it's no longer a crime to be diagnosed with HIV. We're also focusing on an equitable approach by addressing structural and system level changes. And our wonderful colleague, Evan Thornburg, who's joined us on the presentation today, has done a lot of work to design an ACO health policy, first of its kind, health equity policy, first of its kind at the Philadelphia Department of Public Health, where we call out equitable approaches and actually make providers adhere to provider assessments with individualized provider health equity work plans, climate surveys so that we understand staff have meaningful contribution to the work that is being done. And going back to evaluate what is the progress and the inclusion of low health literacy requirements so that people can understand what their options are and what's actually happening. We're also focusing on something called radical customer service, right? Which is a term we've adopted from the business community. And this is what ACO has determined radical customer service to mean. And I don't mean to insult your intelligence by reading off the slide, but I think this is so important. Radical customer service goes beyond providing timely, attentive services to consumers. Radical customer service involves putting consumers first and designing new and innovative processes and programs based on consumer needs as determined by those receiving services. Radical customer service involves soliciting input from consumers and direct service staff without putting the onus on the consumers or the staff. Radical customer service is defining, operationalizing, and providing procedures for assisting consumers that are objective and can be measured and evaluated. Radical customer service requires making adjustments based on qualitative and quantitative consumer surveys, health disparity reports. Radical customer service is utilizing a health equity approach that is clearly defined in protocols and procedures. Radical customer service means transparency for those receiving services and accountability for leadership and staff providing services at every level. And so I leave you with this: an object at rest stays at rest. Everything continues in a state of rest unless it is compelled to change by forces impressed upon it. That's Isaac Newton with the first law of motion. But I think it's so applicable to public health and the work we do in HIV prevention and care services. Is because if we don't, as a community, come together to disrupt the systems as status quo, things will always be status quo. And in 50 years, we'll be talking about how to end the HIV epidemic. Meanwhile, we have the tools to do it now. So with that, I toss it to my colleague, Tanner Nassau, to lead you through an ACO evaluation update.
Thank you, Javante, and good afternoon, everyone. I am Tanner Nassau, and I'm an epidemiologist here at ACO. I think your program also says PhD, which is technically not true until June 29th at 2 p.m. Then you can call me PhD, but until then, I am just Tanner Nassau. We can go to the next slide. So I'm going to spend a few minutes talking about about what we're seeing around HIV diagnoses and care outcomes in Philadelphia, and then I'm going to spend a little bit more time talking about how we are reworking, evaluating ourselves and our funded programs in a disruptive manner, specifically around evaluating barriers to HIV prevention and care, so that we are actively working to improve the delivery of those services to the community. So right now, on this slide, the big takeaway is that COVID made it harder for us to prevent, diagnose, and treat HIV in Philadelphia. This graph here shows that we saw HIV diagnoses, which are in green, decrease around the same time that HIV testing, which is the red line, decreased, which coincides with the stay-at-home orders of 2020 that are shaded there in red. For the most part, testing has rebounded at this point, but we still had months of decreased testing, decreased access to testing across the city as a direct result of COVID. Next slide. And in 2020, we also had 332 newly diagnosed cases of HIV in Philadelphia. That number was lower than what it was in 2019, but we are projecting that in 2021, when we get our complete numbers in here at the end of this month, that they will be higher than they were in 2020. And again, this is due to testing capacity issues due to COVID. But still, there are disparities that persisted even in the face of COVID, with 2/3 of newly diagnosed HIV cases occurring among non-Hispanic Black Philadelphians, followed by Hispanic or Latinx. And individuals assigned male sex at birth accounted for 3 out of 4 newly diagnosed cases. Gay, bisexual, and other men who have sex with men represented over half of newly diagnosed cases in 2020. And this graph here on the left shows that gay, bisexual, and other men who have sex with men continue to be diagnosed at a significantly higher rate than heterosexuals and people who inject drugs in Philadelphia. And finally, we estimate that there are about 2,500 individuals living in Philadelphia who are HIV positive and don't know about their status. Next slide. So we've already seen this slide a little bit earlier, but I wanted to show it again because we know this isn't really the full picture, right? We can say that 78.2% of people living with diagnosed HIV in Philadelphia received care in 2020, or we can say about 2 in 3 were virally suppressed. But we know that there are disparities within these numbers. There are disparities by race, ethnicity, by age, gender, risk factor, as well as other things like insurance status or employment status, housing status, co-occurrence of other conditions like depression. All of these greatly impact an individual's ability to access HIV care. So when we think about disrupting the status quo from the viewpoint of evaluation, what we need to do is move towards making sure those disparities and those metrics are widely known by our providers, widely known by the community, so that in the process of evaluating these programs, we work towards removing barriers that impact these people. Next slide. And then the last data point that I wanted to cover, which was also mentioned a little bit earlier, is that in 2018, we identified an outbreak or an increase in the number of newly diagnosed cases of HIV among people who inject drugs. Again, we saw a dip in 2020 due to testing access and during COVID, but recent trends suggest that the outbreak has continued and it's continued to spread throughout the pandemic. And this is a perfect example for why the status quo isn't going to work for ending the epidemic. The emergence of synthetic opioids as well as housing insecurity has resulted in greater risk for HIV transmission in this population. So we have to evaluate our system on its ability to address those needs. Now let's talk a little bit about what that looks like. Next slide. So our EHE funded programs are intended to disrupt the system. And we want to support those providers and the community in doing so. But where do we start? Well, we know that we don't always get interventions like ART or PrEP or testing to people, which is an implementation problem. And we also know that people don't always want to accept interventions. Both providers and patients don't want to accept new interventions. And that's an adoption problem. And we know that people don't always want to continue an intervention. Again, both our providers and our patients. And that's a sustainment problem. So we have implementation, adoption, and sustainment, which bring us to thinking about how we approach the issues of ending the epidemic, or strategies, what we're going to call implementation strategies. Next slide. This is a logic model that we've developed that I want to spend a couple minutes walking through. So we're going to start in the upper left side of the slide by specifying our outcome, both the EHE outcome, like Anna mentioned earlier, high viral suppression, and then the intervention outcome, like increasing the number of clients who have access to or adherent to ART. Next, we're going to identify the core barriers to achieving these outcomes. For the sake of simplicity, let's say that the barrier here is a missed visit. We also need to identify the specific drivers of that barrier and at what level they operate. So is it a client level barrier, a staff level barrier, or a system level barrier? Maybe the patient missed their visit because they forgot and never received a reminder call. Maybe they missed their visit because the clinic only offers 9 to 5 appointments and they couldn't take off work. These are staff and clinic level barriers that can be overcome by changing procedures around visit reminders and extending or altering clinic hours. The next step in this logic model requires us to identify implementation strategies to address those barriers. So this is the orange box here. I already gave it away, but those strategies might look like a reminder call and outreach to those who missed a visit, or maybe a telehealth option so I can call my doctor on my lunch break. We also need to consider the relevance of these strategies in addressing barriers at all 3 levels. Are we proactively addressing staff and system level barriers and thereby placing the provider in the hard to reach population? Or are we just focusing on trying to overcome individual level barriers and continuing to put the burden on patients to overcome their barriers in a meaningful way? Or are we not addressing barriers at all? In which case we need to add or change our strategies as necessary. Once we do all that, we can fully specify the resulting implementation strategy. And then finally, we specify the intended outcome of that strategy in addressing each barriers. So with our missed visit example, the impact of these strategies is that we increase the number of clients who are seen in accordance with the clinic's HIV management protocol. Next slide. So switching gears a little bit, ACO did some synthesizing of data through one of our projects that worked with facilities and out-of-care patients to figure out what barriers those patients had to engaging in their HIV care. Summarized here are some of those major barriers, like patient rights and education, provider barriers, supportive services, and socioeconomic barriers, and behavioral health. You can see here that patient rights and education was the most commonly reported category of barriers to HIV care. This included things like patients not knowing when to follow up, or they skipped their appointment because they felt too well or they felt sick. All three of these barriers are things that can be overcome if we can get providers to implement a standardized follow-up visit process to ensure that patients are aware when they are supposed to see their doctor next. We also saw that provider barriers were high up as well. These included not being able to take off work or school, having other responsibilities, not having health insurance, or just general appointment barriers, which I think we all are very familiar with. One of the biggest things that we're pushing with our EHE funded providers is extending or altering clinic hours, including evening and weekends, having walk-in appointment availability, and having telehealth options. Again, by framing the provider as a hard-to-reach population, we can begin to make systemic changes to the way that HIV prevention and care services are delivered that reduce the patient's burden of accessing care. Next slide. I don't want to go into too much detail on this slide, but this is really here just to show that an example of education-related barriers, patient expectations, stigma, language, health literacy, adherence knowledge, medical mistrust. All of these things operate within levels, so within providers, but there are also ones that operate between levels. So what we're trying to do is have our providers identify which barriers that they can address at the provider level, at their clinic level, and then what we, ACO, and the health department can do at the system level to increase access to HIV prevention and care services. Next slide. So I'm going to finish here and talk a little bit about how we consider, measure, and advance equity in the implementation of EHE programs and why it's so important. Really thinking about redesigning the system so that addressing health equity is ingrained in the ongoing process is key to ending the HIV epidemic. Our EHE disruptive strategies need to have stakeholder engagement and collaboration at every step. That's essential to the adoption of the strategy. Those strategies also need to come from multidisciplinary teams and partners, which is essential to making sure that those strategies are sustainable. And those strategies have to be developed with an understanding and ability to measure context. So my barriers are different from your barriers, which are different from her barriers, which are different from their barriers. And they need to be practical, actionable, impactful, and real world if they're going to make an impact on health equity and HIV prevention. And that's the direction that we're trying to move with EHE evaluation and making sure that we are capturing that context and capturing what makes it hard for one person to access one provider at a time and trying to build it out from there. And with that, I think I pass it back over to Javante.
Thanks, Tanner. So you've heard Anna talk about the EHE initiative, right, as a system-wide national project. And then you've heard Anna describe how we're implementing it on a local level. I talked a little bit about a disruptive community and how we can start to build that. Tanner led us through an excellent overview of our evaluation efforts for EHE. And now we want to talk a little bit more about some of our prevention programs that we're able to do with the EHE supplemental resources that we've received. You know, the health department funds HIV testing, but these programs that you're about to hear, you may not be as familiar with. So I'd like to toss it over to our colleague, Brian and Amina, and we're going to hear from Brian first with a little bit more about our prevention programs on the low threshold front. Brian?
Thank you, Javante. Good afternoon, everybody. My name is Brian Hernandez. I am the telehealth program coordinator. Can we go to the next slide, please? So for our prevention programs, we're currently funding 5 clinics to provide low threshold sexual health services. And these clinics have been funded since July of 2021. Each funded agency has a population of focus for their sexual health services, and these include Black African Americans, Latinx individuals, Southwest Philadelphians, and the LGBT community. Next slide. All agencies are funded to develop and implement core components of low threshold sexual health services, which are community engagement, low threshold access, and sexual health services. And through these core components, the aim is to diagnose persons with HIV at risk of HIV acquisition, link newly diagnosed people living with HIV quickly and effectively to care, link persons with PrEP indications to PrEP and MPEP, and provide a range of sexual health and other preventive services. Next slide. Now we can move forward with discussing the Philadelphia Teleprep program. Through a partnership with Albert Einstein Medical Center, PDPH is implementing its first ever Teleprep program. Through this program, PDPH aims to expand PrEP access in Philadelphia by providing free Teleprep services through the Philly Keep on Loving website. This program will be available to all Philadelphia residents ages 17 and up, regardless of gender identity or sexual orientation. When we take into consideration the CDC's updated guidelines for PrEP to be recommended to all sexually active adults and adolescents, this program will really be a great way to expand access and create more opportunities for Philadelphians to get on PrEP. Next slide. So another program that's promoting expanded access is the HIV self-testing program. Through this program, PDPH provides free or quick in-home HIV tests to all Philadelphia residents through the Philly Keep on Loving website. We currently partner with 10 community-based organizations that provide self-test kits on site, as well as fulfill mail order requests on behalf of clients. And given our current COVID-19 pandemic, the HIV self-testing program has really helped expand opportunities for HIV testing in Philadelphia. Next slide. So what has our reach been with this program? Just last year, we distributed over 2,000 test kits across Philadelphia County. And when we break that number down, this is what our distribution looked like. So 842 kits were distributed through mail order, 309 kits were picked up across CBO sites, and 972 test kits were distributed across our CBO partners. Next slide. So I've mentioned Philly Keep on Loving a few times now, and I bet some of you are curious as to what it is. So for those who aren't familiar, Philly Keep on Loving is PDPH's sexual wellness website that offers free sexual wellness products, resources, and information for all Philadelphians. All sexual wellness products that we provide can be delivered at home for free. These products include at-home self-test kits for HIV and other STIs, such as gonorrhea and chlamydia, house calls for syphilis, as well as condoms and lubricant. Philadelphians can also access information on syphilis in Philadelphia, resources on PrEP for HIV prevention, as well as geographical maps of HIV testing locations and PrEP providers in the city. And lastly, we do have some big updates coming to the website. This includes new social media campaigns for HIV self-testing, Teleprep, anti-stigma, and U equals U, or undetectable equals untransmittable. Next slide. Oh, sorry, can we go back one? My apologies. So including the social media campaigns, we'll also have expanded resources for PrEP, PEP, and HIV testing. And we also have an integration of PDPH's Do You Philly for STI testing and condom and lubricant distribution. And as I had previously mentioned, the Philadelphia Teleprep program. Next slide. So lastly, what I have here is just a visual of what the sexual wellness products that I had previously mentioned look like. Prior to our integration with Do You Philly, Philly Keep on Loving only offered HIV self-tests, regular condoms, and lubricant. But now, thanks to Do You Philly, the website now offers non-latex condoms, Magnum condoms, insertive condoms, also referred to as female condoms, and STI at-home test kits for gonorrhea and syphilis, as well as house calls for syphilis testing. Next slide. And I will pass this over to Amina.
All right, good afternoon. My name is Amina McCann Woods, and I am a health program analysis supervisor at ACO. First, I just want to, say how grateful I am to actually be a panelist after many, many years participating in this capacity. It's truly a pleasure and an honor to do so. And until we meet again in the hallways, I will, of course, always be with you guys. So today we'll be talking about harm reduction program updates. And just to let you know, ACO is finally stepping into the 21st century of providing, harm reduction services. Next slide. All right, so first we're going to talk about the Philadelphia Center of Excellence, PEP services. PEP Center of Excellence is the most recent addition to our efforts to end the HIV epidemic. It was established in the fall of 2021. Services began launching on April 1st, 2022, and is currently being delivered by a trusted hospital network here in Philadelphia. PEP COE is a 24/7 service available to anyone in the Philadelphia area. And the main tenet is to provide a low barrier, non-gatekeeping access to respond to people in need of emergent care for PEP services. Next slide. The PEP COE, or Center of Excellence, conducts quality assessments for someone who presents a need for PEP services. So if they're eligible to begin PrEP, they will work directly with a clinician to begin PEP treatment by getting a 3-day starter pack. And following this, the person will work with a clinical team that consists of a clinician, a coordinator, and a navigator to see them through the entire regimen and for additional support. So here's the phone number. It is 1-833-933-2815. And this is how you access PEP services. Next slide. All right, next we'll be talking about syringe services programs here in Philadelphia. There's one, and it is a community-based harm reduction prevention service who help people who are currently injecting drugs to get them access to clean needles. This is done through a one-to-one exchange for used needles. The SSP provides a range of services that include access and disposal of the sterile needles, sterile syringes and injection equipment, vaccination, testing services, harm reduction counseling, connecting to medical care and supportive services, and this is just a few. Syringe services have been available to people who inject drugs since 1992. Services are accessible in the community Monday through Saturday, currently providing at least 29 hours of services per week. And this also includes mobile syringe services. Next slide. So the syringe service program touches all pillars of the ending the epidemic, which is diagnose, treat, prevent, and respond. And of course, Philadelphia's local fifth pillar, which is health equity and radical customer service. But beyond needle exchange, SSP serves the whole person. The syringe service program works to prevent infectious diseases, namely HIV and Hep C. So if a person contracts any illness, they'll be navigated to engage services such as PrEP, PEP, medical care, behavioral health services. And the syringe service program has rendered services to thousands of Philadelphians and those from the surrounding area. The exchange has distributed millions of sterile needles. Last year alone, for 2021, the SSP exchanged more than 7 million sterile needles in exchange for used needles. And just to let you know, that number is increasing. So I just want to also say that, the SSP is always considering the needs of the community, especially in the age of the COVID pandemic. The SSP continues to increase capacity and reduce barriers to access to service. Next slide. And finally, we'll be talking about another new addition, the SANA Clinic, which is a low threshold clinic here in Philadelphia. It was opened in the spring of 2021, which was in response to a growing need to provide low barrier HIV primary medical care to people who use drugs. Some of the services that the Sonic Clinic provides is medical assisted therapy or MAT, hepatitis C virus testing and treatment, OBGYN care, or also known as reproductive care, immunization services, PrEP, medical case management, wound care, and pharmacy management. Currently, the clinic is open 5 days a week and providing 32 clinic hours. There are plans to scale up services to 7 days per week, including nights and weekends. The clinic staff composes 3 physicians, 1 nurse, a navigator, and 2 bilingual medical case managers. And to date, they have served over 60 patients with over 400 clinical visits among them. Next slide. And I'm going to toss it over to Ms. Ferrioli.
Hello, I just have one more thing for you about the EHE Regional Collaborative. Next slide, please. All right, so one of the ways that we are working to really build out our practice around our practice and improve our system to end the HIV epidemic is the establishment of the Philadelphia Regional EHE Collaborative. It intends to bring together a team of partners across care settings to engage in shared learning. The group works to improve the system of HIV care and prevention, and their shared goal in this learning is to end the HIV epidemic in the Philadelphia region. It's organized into time-limited and topic-specific working groups, so we never just meet for the sake of meeting. The Health Federation serves as our convener, and the sessions are facilitated by ACO EHE staff with guest facilitation by subject matter experts as needed. The first working group has been the immediate ART working group, which has been meeting since November of 2021. It's met monthly, and it has included presentations by EHE team members, and there've also been session discussions with attendees. These have focused on practical challenges to immediate ART implementation and strategies to address them. So it's taking this idea into practice by working with providers to make sure everyone has a shared understanding of the issue and how to carry it out. The next working group will focus on integrating health equity into HIV prevention and care practice. This information will be used to reduce stigmatizing experiences, which we expect to improve health outcomes for marginalized Philadelphians. Next slide, please. All right, passing it on to Dr. Brady.
All right, go ahead and give me next slide. All right, so to really wrap up this presentation, I wanted to talk a little about where we go from here. And so one of the next steps for ACO is really to update our EHE community plan. And that's really because we've accomplished a lot since we released that plan in initially in December 1st of 2020. And so there's more things for us to do to really reach ending the HIV epidemic goals. And so one of the things that we've been working on this year is looking at the National HIV/AIDS strategy. So early this year, the White House's Office of National Policy, or ONAP, facilitated the development of the National HIV/AIDS strategy, which has been updated for the years 2022 to 2025. And so the National HIV/AIDS strategy has 21 objectives and 78 strategies for federal and non-federal partners, including local jurisdictions like Philadelphia, to implement and achieve the goals of NHAS. And they're the same as those for ending the HIV epidemic: to reduce HIV infections by 75% by 2025 and by 90% by 2030. And the goals for NHAS are a little bit different than it is for EHE, but there's a lot of overlap. And so the first is to prevent new HIV infections, same as EHE, to improve HIV-related health outcomes of people with HIV, which is similar to the treat pillar, to reduce HIV-related disparities in health and equities, very similar to our Pillar 0, and achieve integrated and coordinated efforts that address the HIV epidemic among all partners and stakeholders. And so ACO has reviewed the NHAS and the different objectives and strategies, and is including those things that are new in NHAS into our EHE community plan with an eye towards further disruptive innovation. And so once the EHE community plan is updated with that, the new NHAS information and some updates on what we've been able to accomplish so far, there will be further community engagement events so that we can get an additional input from community such as those attending today. And so, you know, my last bullet point in here has been something that I think Javante brought up at one of our internal meetings, and it's just something that stuck with me. I've worked in HIV for a very long time. I don't even want to say how long, a very long time. And so HIV is my passion. And I really, you know, the motto of ACO, I would say at this point in time, is that we are all in it to end it. And that is our motto for 2022 and further until we actually end the HIV epidemic in Philadelphia. And so we'd like to hear, I think now from folks in the audience, and I think we can open it up to questions. Yeah,
Good job, everyone.
And I was going to have everybody turn on their cameras. Okay, thank you. Oh, there was an answer in here. Oh, thank you. Tanner actually put the question, the answer in there. Thank you. I was looking for it, but then I had to speak. So there was a question, is there data demonstrating the drop in infections and deaths as a result of the needle exchange programs in their targeted areas? And there's actually a large body of evidence to support syringe service programs. Stay tuned for some information being released from the health department on that. But there's actually a paper that was released a few years ago from colleagues at George Washington University that looked at implementation of syringe service programs in Philadelphia and Baltimore in the first 10 years after implementation. And so the official year that they were looking at in Philadelphia was in 1992, when syringe service programs became feasible through an executive order by then Mayor Ed Rendell, because syringe service programs are actually still illegal in the state of Pennsylvania. And so they still operate under that executive order. And so that paper was able to show through modeling that there were 10,000 HIV infections averted in the first 10 years of the syringe service program. Some people may wonder why then we are seeing an increase in those cases of HIV in the last few years, and that's really related to fentanyl and that the increased need for the number of injections. So fentanyl it doesn't stay in the system very long, so people have to inject much more frequently. People are often injecting more than 10 or 15 times a day. And they need to basically use a sterile syringe each and every time. And so if there's insufficient supply, people basically will end up sharing. Do we have any additional questions?
At this time, there are no additional questions. We can give them a few minutes, see if any trickle in.
Well, I was going to say, while we're waiting, we can go ahead maybe and say a few more words about a couple things.
We did get something in the chat box.
Yes, I see. Thank you. And thank you. We appreciate you attending. I'm going to put Evan a little bit on the spot and just have her sort of, maybe give a summary of of some of the things she's been working on lately, and anything that she's seen that she sort of wants to highlight in her work.
Ooh, on the spot. Of like the post movie kind of like little tidbit, sort of like in a Marvel movie. I feel like that scene now. Welcome to the multiverse. So my name is Evan. I use she or they pronouns. I am the Health Equity Special Advisor here at ACO. One of the key things that I've been working on, exactly, Javante. One of the key things I've been working on in this year, I've been here since August 2020. Obviously, the first thing for me was to do structural things like the health equity policy. That's a living, breathing document. That's one of the things I like to make sure I mention, is that every year I reassess it and I edit it and update the language on it and the goals on it. So, sorry, what you would have seen from the document in 2020 is not what you would have seen in 2021. It's not what you'll see in 2022, because I think that with things like health equity, we constantly have to be moving forward and be malleable to change and what's best practice. The other thing that I've really focused my attention on after doing provider assessments that I really want to share with people, and I want people to get very interested in, is health literacy, low health literacy. In a city like Philadelphia, this is a huge, huge barrier for folks. The average American reads somewhere between a 5th and 8th grade reading level. When you apply poverty, which Philadelphia has a very high poverty rate, before the pandemic it was around 24%, 24.1, somewhere around there. And after the pandemic, it's floating up towards about 27% of the city identifies at or below the poverty line. What this means is that people's literacy level starts to fall as well, in general sense. So in Philadelphia, we may have folks who, as adults, working, commuting, doing all sorts of things, who may have literacy as low as second to third grade. This is super important when you're trying to impart information about someone's health and health care. And it can be as simple as things like how you give them directions around medicine. So things like saying take twice a day is not clear enough information or instruction. You want to say things like take once with breakfast and once with dinner. That is more clear, and that has to do with literacy. Same thing with things like numeracy, and then color perception as well for disability access. And so all of that's to say is that health literacy has been a huge component this year around adapting our programming. We're hoping to release an HIV low health literacy guide in the coming months. We're in the final draft stage of that, and that would be downloadable from, I think, our website. Is that right, Kathleen? That's easily distributed. It has all sorts of guidance around how you want to give presentations and how you want to make resource materials, how you want to make digital resource materials, how you want to create digital access, because health literacy also includes digital literacy and digital access. So those are the things I will mention. And then also that we are doing the Health Equity Institute for anybody who's a professional. They can sign up with Anna, I believe, for that working group, and that starts sometime in September, and we'll be going through different intersectional groups and identities that are target populations, but we'll be talking about, it's very interactive even though it's virtual, and we're hoping to do a lot of workshopping around how we can better be inclusive spaces for those groups.
For 12 months?
Yes, once a month for 12 months.
12 months, yep. Okay, so we do have some questions in the Q&A, and so I can read them and see who might want to respond. If someone wanted to be a part of the community events, how would they go about it? And so I have, oh, yeah, okay, Anna put a response about the Health Equity Institute in the chat. Does anyone want to talk about how folks get to attend community events? I mean, we basically hold webinars, we widely distribute information to our, our contacts in community-based organizations, and who can further, distribute it to their community members and listservs about when it is, and then people can register and join community events. Does anyone want to add anything to that?
Yeah, I think, community events in the age of COVID are a tricky thing because you have a lot of people who are comfortable going out amongst the public and a lot of people who aren't there yet. And that's okay because COVID is still a thing. So it would be irresponsible of the health department to tell you, go to all the community and get events you can and engage with everyone, so we're not going to promote that message. But I think what we're talking about when we say build a disruptive community is sustained engagement, because there's a cycle of people getting really excited. And I'm not saying you, Dina, but there's a cycle of people getting really excited about a certain cause, and they go and find out what they can that's happening at the moment, but then the advocacy drops off. And so I would say the best thing you can do is to engage with the HIV Integrated Planning Council through the Office of HIV Philly, and that is hivphilly.org, because they're definitely looking for bodies, people to be engaged in this work. We're in the process of the next 5-year plan for how we're going to treat and prevent HIV in Philly. The second thing I would say is to go on phillykeeponloving.com and look at PrEP places near you. All of those places have some type of community advisory board or some type of way that you can get on their mailing list and become more engaged and closer to the work that they're doing, particularly with outreach amongst people who are priority for PrEP outreach or people who are in a focused population. And then the last thing I would say is you can send any one of us your email address and we will add you to our listserv. Brian prepares and publishes 2 updates a month. If you're a provider and you're interested in PrEP, we have a PrEP update that goes out once a month. It has some of the most cutting edge science, some links to trainings, and we also send widely to the community the prevention update, where people can stay engaged with things that are happening in the world of HIV, particularly in the world of HIV Philadelphia, right? And so those are the 3 things that I would say, if you're looking to get more involved in the work or just be more connected to things that are going on, definitely seek out the Office of HIV Planning, definitely seek out Philly Keep on Loving providers that are listed, and email any of us and we'll add you to our listserv.
And they can also send an email to preventhiv@phila.gov. That's our Prevent HIV mailbox, and you can request to sign up for either of those newsletters. Okay, so we have another comment that you are taking some radical steps by flipping the idea of who is hard to reach. What, if any, resistance are you getting or do you anticipate getting from local organizations with some of these changes? So change is a process. There's actually a lot of science about change, and so it is a little bit difficult. So we are getting, there are times we do get some degree of pushback, but this is a collaborative process, and basically the way we make change is to listen to people, listen to their point of view, explain our point of view, and hopefully we can move people along in the right direction, so that we can implement disruptive change. Change is difficult for everybody. It's disruptive as well to our lives, our schedules, etc. And so it definitely is a process. But I think we also have very good collaborations with our funded partners, and they really also are committed to ending the HIV epidemic. And so I think that's really a good place to start.
Can I add something? Anna, were you going to add to that also?
I was.
I saw you reaching. Go ahead.
So the main thing I would add is that really some of our greatest partners in making these changes are really heroes at the facility level, people at agencies and facilities who really buy into these concepts and want to take a chance and try something out. And once they try it, they then able to share what they know and what their experience was and why it's worth it with their fellow providers.
Amina?
Just one thing I wanted to add was ACO being on the same accord. We have made it our mission to read and understand the ending the epidemic plan, and us having, one voice and being on the same page, speaking the same language to our provider agencies and the folks that they serve, participating in a panel such as this is also part of that change process. And like Dr. Brady said, change is hard, but some of the change is needed change, welcome change. And actually, we've heard some very good ideas in this process over the last few years. So just, being on the same page and speaking the same language is part of that process.
So my colleagues have given very diplomatic answers because they're all very stooped in health department and bureaucratic speak. I am going to say, I'm going to add and say, you will either come willingly and apply to an RFP to be well-funded, or we will drag you to ending the epidemic. There is no not going, right? The way you blow up the clog in a dam is to blow it up, right? And so when we're talking about radical customer service, we're talking about building a disruptive community. Think about those two things don't really go together, but disruption and community can occur, right? And when we have those two things, it makes a massive impact, because it's not just the health department speaking to people about some initiative, it's about the community building with us to make lasting change, right? And so this isn't optional. It's not a box that you check and say, oh, yes, I'd like to end the epidemic today. This is what we're doing. And I think in that way, Philadelphia is very much committed to an activist type of public health that is really meaningful about health equity, that really centers the lived experience of people living with HIV and those at high risk for HIV or higher risk for HIV, right? We're talking about racial justice. These are not the common conversations that are popular to have at this political moment, but this is what we're committed to. Because as Dr. Brady has said, and I completely concur, we are in it to end it. So, resistance is expected, but it's not going to be accepted.
Yeah, and I'm not going to hang Javante out to dry at all here, but no, and a lot of the programs you've heard about today actually are things where we did put out requests for proposals for people to submit. We were very clear in what we wanted and the expectations for this new funding. And so if you submitted a proposal to do something else rather than what we want, you're not going to get funded. So that's really one way to really kind of bring people along in the right direction. And so we've got people who applied for this, for these programs, who are committed to do the work and understand why we want to do them the way we want to do them.
And the last thing I will say is that I'm not making these statements from the ivory tower of the health department. We have done intensive listening to community. And so the programs that we're investing in are what we've seen and heard from the community that they need, right? It's not, oh, this group of folks at the health department are deciding what's best for us. And so the reason I can challenge resistance is because we have the community on our side. Somebody just dropped in the chat that they are in agreement, because this is what it's going to take to end the epidemic, and why maybe we haven't gotten there sooner, right? And so it's not just you do this, it's come along, tell me what we should be doing, what should we be investing in? Let's consider new ideas, let's talk about different innovative strategies. And so you have some moral authority when you include people in the conversation.
All right, and so from our own Andrea Harrington, she's asked, how does it feel to be an example of leadership in forging change in the way we better serve our participants and being a guide for other sites across the United States? And so I'm honored that Andrea, you see us that way. I think you know, I appreciate that very much. It really, and I would say that for the same thing, I think it's an honor that we are implementing the programs that we're implementing. There are so many things that I've been so excited about in the last couple of years. You know, having a Teleprep program was not something I would have ever imagined was possible 2 years ago, or I guess a little over 2 years ago, before the pandemic. And, you know, that's sort of one of those things where the pandemic has allowed us to achieve things that weren't otherwise possible. So when that program officially launches, people are going to be able to go onto the Philly Keep On Loving website, be able to get an appointment with a PrEP navigator, talk to them about whether PrEP is right for them, get lab work, either to go to a drawing station somewhere like a LabQuest or a LabCorp, or get home testing sent to their house and have a virtual appointment with their provider through telemedicine, through that portal, and never have to really get all of that, get their meds delivered to their house and never have to leave their home. And I think that's really going to increase access to PrEP. But that's slightly off topic, but that's basically, I get so excited that when we talk about programs like this, because, you know, that is something that's very innovative. That unfortunately, you know, the pandemic made it possible. But, you know, that's sort of one of the flip sides. And so, and I think it's really going to make a big difference. And it's something that we're very excited to share with other folks around the country after it's implemented. So my word would be, I feel honored. And so I don't know if other folks basically want to add their comments to that.
I feel a tremendous sense of pressure and responsibility because people are looking. They are looking, you know, as a phase 1 jurisdiction, there's a lot of investment in EHE particularly, but we've hyped the city to say we're doing things different. We're ending an epidemic, right? And now we have to do work. Everyone at ACO, including, you know, Andrea, you, as Kathleen said, one of our own, everyone at ACO is wearing a lot of hats. Nobody more than our director, our acting director, Dr. Brady, but everyone's being pulled in several different directions as we try to accommodate this influx of resources and also getting the money on the street so that our providers have what they need, but then there's a bunch of technical assistance that needs to be done because they may not have all of the capacity to do something. And we may not have it in-house, and now we have to go and see, like, what expert can we bring in? Like, what national resource do we have? Tanner mentioned implementation science. We're having a consultant come in who's nationally recognized to help us do that, right? Very quickly. And so when we think about all of these different things, there's a tremendous sense of pressure and responsibility to get it right. And honor. I feel honored too.
Anyone else?
I would say it's also a privilege. I moved back to Philadelphia. I grew up in Frankfurt in the 80s, and I moved back to Philadelphia in December 2020. And I sort of never could have dreamed I sort of ended up where I am doing what I do. And I am, you know, I just feel very privileged. You know, a lot of people I grew up with didn't come out of it. And, you know, I'm here on the other side getting to do, you know, getting to do the work and getting to push to make the city better. Also, I came here from New York. New York thinks it's the best at everything. And I love that our federal partners reach out to us and ask us how to do things in Philadelphia, because we do know what we're doing. And I'm really proud of the colleagues here. There's just so many people who are so knowledgeable and so committed and keep the focus on the work and the community. And it's just really a great thing to be part of.
And I guess I would add here that, keep it short and simple, that I'm privileged, but I'm also a part of the community that we're serving. So I want to keep myself grounded always, because not only, you know, when we say serving Philadelphians, I'm a lifelong Philadelphian, right? Born and raised in North Philly, right? So I want to keep that always at the centerpiece of how I do my work and how I approach it. So just wanted to add that. Thank you. Thank you, Bill.
I wanted to add that we have 2 messages in the chat box that says, "It takes a village." And I love the fact that both folks said that. I believe all of the questions were answered. We do have one left from Teresa Sullivan. Kathleen, if you would like to read it as well.
Sure. Many of participants will not have the knowledge of how to use a patient portal. So the implementation health literacy implementation health literacy, it includes tools that we can use in our educational programs, and will there be a guide from ACO when it will roll out? That's a absolutely great suggestion, and absolutely, you have it from my mouth right now that yes, we will definitely make sure that we will have clear guides to make it easy as possible. And so, and there's definitely, you know, there's people are going to be able to sort of set up appointments, and they can decide how they want to do it depending, you know, it could be that someone's calling them on the phone, they can have the ability to text, etc. So it's going to be versatile to make sure that we can definitely meet the needs of individuals, and certainly we don't want to add to the digital divide that the COVID pandemic has caused over the last few years.
I can also add that, so the health literacy guide, it's a little bit of a misnomer because it's not exclusive to literacy, not in the general sense that a lot of health literacy tools are. I did want to make sure that I kind of combined every element of what compacts people's abilities to understand. And so there is an entire section on digital tools, both for the provider, like how to create digital tools that are very well understood. So like easy to navigate, like websites, what do you need? Including things like alt text and imagery on like PowerPoints. All of that's in there. It was also imperative for me that in providing a guide for these things, that the guide itself wasn't a barrier. So I can also confirm that the guide itself reads at about a 5th to 6th grade reading level. So you could give this to your elementary school student at home, and they could understand how to implement better practices. Alongside of that, there is a presentation. There's about a 45-minute to 1 hour presentation where you can learn about how to implement these things in lower health literacy for your clients in your space. But patient portal is actually highlighted distinctly in that guide. And the main suggestion is, number 1, to walk people through setting it up. So if that looks like having, I know some places, some organizations have already like a terminal, like a computer terminal available, but sitting with a patient and actually walking them through setting it up. And this is par for the course because a lot of clinical spaces already do things like this for like applying for care credit, for example. I was at the dentist the other day and they sit with you and they help you apply for care credit. They sit somebody right next to you. So we can do the same thing for setting up the patient portal, which is different than navigating it. And then the second item around patient portals in the guide is instructing people to then set it up on people's device. So that might be their cell phone, if they bring in their tablet, but making sure that a patient has it pulled up on their device and can see how to navigate it from their device. So very, very important. And then also showing them which tabs they'll need to use. So all of that's in there, like those suggested items, which will be distributed when we get it up on the website. And we're also going to distribute it to our providers and to our own staff as well.
Thank you,
Okay.
Evan. And we have 2 more comments. Yes, thanks, Evan. We don't need more barriers in healthcare. I like the fact that you are including virtual learning because of low literacy issues. We don't have any more questions. So if that's it, if there's any more questions, please put them in at this time. But I want to thank you all again so much for participating and for your wonderful presentation. And thank you to our viewers for joining us today. Please continue to join us for our future presentations. Let's see. Yes, no more questions at this time.
All right. Thank you, everyone. Thanks for participating.
Great presentation. Thank you.
Thanks, Kat.
Thank
Okay.
you.
All right. Bye-bye.
Thank you.
Take care, everyone. Bye.